Bullous pemphigoid group, or the subepidermal group of bullous diseases, first disease is the bullous pemphigoid disease. Here we make a comparison between the bullous pemphigoid and cicatricial pemphigoid, and also the bullous disease of pregnancy, or pemphigoid of pregnancy, which is the herpes gestationis. First, bullous pemphigoid. Bullous pemphigoid is a chronic benign subepidermal disease which has a self-limited course and benign course with remissions and exacerbations, and with a low mortality rate. Epidemiology, usually in old age, more than 60 years, but good general conditions. It happens also in juvenile bullous pemphigoid in children, and no racial or sex predelegation. Clinical picture: localized at the flexurals, but sometimes generalized, bully, tense bully. It occurs on normal skin and on arterial wheels, plus or minus mucous membrane, up to 40%. So it is tense bully on normal skin and arterial wheels. There is erosions and crustaceans, and heal by hyperpigmentation. Pruritus usually generalized. Sometimes it presents as an arterial lesions and then develops into the bully. So it is localized in the flexures, but sometimes generalized, tense bully on normal skin and arterial wheels, with erosions, crusts, and hyperpigmentation, mucous membrane rare and sometimes up to 40%, and pruritus usually generalized. There is variance of the disease: juvenile, localized vulval pemphigoid, localized oral pemphigoid, and lichen planus pemphigoids and bullous. Of course, there is differential of bullous lichen planus. Lichen planus pemphigoid, it occurs all. Some bully are on the lichen planus, and some on the normal skin. But for the bullous lichen planus, all bully on the lichen planus lesions. So we said there is juvenile types, there is localized types, localized vulvar pemphigoid, localized oral pemphigoid, lichen planus pemphigoid, vesicular pemphigoid, pemphigoids nodularis, dyshydrosiform pemphigoid. There is other associations with the disease, with some autoimmune diseases like rheumatoid arthritis, LE, pernicious anemia, and also it occurs with UVB, PUVA, furosemide, Lasix, and penicillamine artamine. It is sometimes associated with internal malignancy, so it is in paraneoplastic syndromes. This is the clinical picture. You can see here the tense bully on arterial wheels and on normal skin. And here also we can see tense bully, especially on the flexurals in old male patients. We give a comparison also of the cicatricial pemphigoid. There are two separate diseases, but we'll talk about them. And cicatricial pemphigoid is a chronic blistering disease with prededication to mucous membrane 100%, mostly ocular and oral, scarring, skin if it happens 10 to 20%. Mucous membrane 100%, oral in the form of desquamated gingivitis, recurrent blisters that heal with painful erosions and heal with scarring, ocular as chronic conjunctivitis, conjunctival vesiculation, eyelid edema, scarring, symblepharon with corneal ulceration, and sometimes blindness. Less frequent sites like pharynx, causing hoarseness of voice, esophagus, dysphagia, and rectum pain and defecation. Skin lesion, when it occurs as vesiculobullous eruption only on the scalp and face, and heal with scarring in some areas. This is the clinical picture of cicatricial pemphigoid, oral mucosa, as you can see, on buccal and hard palate. We will talk about the histopathology. The histopathology of bullous pemphigoid, subepidermal bully with eosinophils. Also the same with cicatricial pemphigoid, subepidermal bully with eosinophils. The immunopathology, the direct immunofluorescence with skin biopsy, of course, perilesional skin. There is immunoglobulin G and complement 3, 100% in basement membrane zone in the lamina lucida. Linear homogeneous deposition along dermoepidermal junction in lamina lucida. Indirect immunofluorescence, titr is not correlating with disease activity, and there is immunoglobulin G against bullous pemphigoid antigen in dermoepidermal junction. Circulating immunoglobulin G autoantibodies against bullous pemphigoid antigen dermoepidermal junction. Immunoglobulin G1 only fixed complement. Immunoelectromicroscopy in the lamina lucida, in the roof of bulla. They are almost the same with the cicatricial pemphigoid, but direct immunofluorescence is positive only in 80% and indirect only in 20 to 30%. The salt split skin technique, separation of dermoepidermal junction through lamina lucida. You can see there is the separation in the roof only, as here, bullous pemphigoid, cicatricial pemphigoid, herpes gestationis, and labbed the majority. And there is other diseases in the base only, like epidermolysis bullosa acquisita, bullous systemic lupus, and rarely in bullous pemphigoid and cicatricial pemphigoid, and the minority of labbed. For DH, it is negative. This is the histopathology and immunopathology of the disease. As we can see here, you will see first the histopathology. The histopathology, subepidermal bully with eosinophils. Here also another picture, subepidermal bully with eosinophils. And for immunohistopathology, at the roof of the blister, as we can see here also at the roof of the blister. Pathogenesis and treatment of bullous pemphigoid and cicatricial pemphigoid. The pathogenesis: bullous pemphigoid antigen 1, 230 kilodalton protein, which is more common, and bullous pemphigoid antigen 2, 180 kilodalton, which is more severe. The cicatricial pemphigoid antigens are the same, but also there is laminin 5 and integrin. What happens in all subepidermal bully, the rule is binding of antibodies to their target molecules lead to influx of inflammatory cells, which are either eosinophils here, like here, or neutrophils in other diseases, leading to release of proteolytic enzymes that digest cell to matrix adhesion, leading to blister formation. So there is here binding of antibodies to their target molecules, leading to influx of inflammatory cells, eosinophils, leading to release of proteolytic enzymes, digest cell to matrix adhesion, and blister formation. Exactly what happens is that recognition of bullous pemphigoid antigen as foreign leads to formation of bullous pemphigoid antibodies that bind to dermoepidermal junction, complement fixation, mast cell into dermoepidermal junction, leading to release of eosinophils, chemotactic factor, and eosinophil in dermoepidermal junction, proteolytic enzymes, and separation of the and bulla formation in the lamina lucida. The treatment here, we give steroid in low doses as an anti-inflammatory, not like in pemphigus vulgaris we give steroid in high doses as in pemphigus vulgaris. So we will give now treatment for bullous pemphigoid, steroid, as we said, as small doses as anti-inflammatory, If it is localized, we give potent topical steroid. If it is generalized, we can give low dose as 40 to 60 milligram prednisolone per day. And also Dapsone, 100 milligram per day is another option. Oral tetracycline and nicotinamide, 500 milligram 4 times per day for tetracycline, and nicotinamide 500 milligram 3 times per day. And immunosuppressives as azathioprine, Cellcept, or methotrexate used in steroid sparing from the start. Intravenous immunoglobulins and cyclosporin A. This is the treatment: steroid, Dapsone, oral tetracycline, nicotinamide, immunosuppressives. What about the treatment of cicatricial pemphigoid? The same: steroid, local injection of steroid, oral or ocular, and systemic low dose, also not high dose, as 40, maybe up to 60, and Dapsone, topical cyclosporin, surgical interference. Herpes gestationis or pemphigoid of pregnancy. Herpes gestationis is a pemphigoid of pregnancy. As we said, it is one of the specific dermatoses of pregnancy. It occurs in the second or third trimester, characterized by flares at the delivery time and remits slowly postpartum. Sometimes there is exacerbations postpartum period, and it also can occur with trophoblastic tumors and contraceptive pills. It is one of the specific dermatoses of pregnancy, usually in the second and third trimester, with postpartum exacerbation, sometimes with trophoblastic tumors and contraceptive pills. There is HeLa association, DR2 in the father, DR3 and 4 in the mother. Clinically, it occurs mainly on the extremities and trunk abdomen, especially the umbilicus. There is a bully on the normal skin and erythematous and urticarial wheals. Plus or minus mucous membrane only on 20% of cases. It is extremely pruritic lesion, and it occurs, as we said, like bullous pemphigoid in a pregnant woman. Bully on normal skin and erythematous and urticarial wheals. As we can see here in the picture, and also in these pictures, this is pemphigoid of pregnancy or herpes gestationis. Hence bully on urticarial wheals and on normal skin. Here also is another picture. Histopathology: the same as bullous pemphigoid, subepidermal bully with eosinophil. Immunopathology: the same, direct immunofluorescence. Here complement-3 immunoglobulin G and complement-3 especially 100% complement-3, sometimes immunoglobulin G in 40 to 50%, and dermoepidermal junction base membrane zone in lamina lucida. Indirect immunofluorescence: linear homogeneous deposition along dermoepidermal junction in lamina lucida. 25% immunoglobulin G and 90% immunoglobulin G1. It is herpes gestationis factor. Immunoglobulin G1 only fixed complement. So there is usually linear deposition of immunoglobulin G and complement 3 on basement membrane zone. Also the immunoelectron microscopy in the lamina lucida in the roof of the bulla. What about the pathogenesis of the disease? It is also called by bullous pemphigoid antigen, but here mostly the bullous pemphigoid antigen 2, 180 kilodalton protein mainly. Mostly in bullous pemphigoid, the bullous pemphigoid antigen 1, which is 230 kilodalton protein. But here is bullous pemphigoid antigen 2, 180 kilodalton protein. The pathogenesis: the herpes gestationis is an autoimmune disease triggered when a woman with an immunological susceptibility is exposed to antigen derived from her sexual partner, the father. Herpes gestationis antigen develop immunoglobulin G that fix the complement, antibodies against the immune, bullous pemphigoid antigen 2, 180 kilodalton protein, and recognition of bullous pemphigoid antigen as foreign, and once it is initiated, it is hormonally mediated, and it occurs in subsequent pregnancies. So the bullous pemphigoid antigen is bullous pemphigoid antigen 2, 180 kilodalton protein. Treatment is steroid Mild cases, we give topical steroids. Systemic, we start from 20 to 40 milligram per day prednisolone with antihistamines. Dapsone is contraindicated. Hemolysis of the neonate. Oral contraceptive is contraindicated. Neonate should be assessed for the steroid treatment for adrenal suppression, and also cleft palate could happen, and also the antihistamines should be assessed for drowsiness. Sometimes we do plasmapheresis, and also there is a note: postpartum exacerbation is common, and disease even may start after delivery. So this is the treatment: steroid mostly and antihistamines. And here we can see the histopathology of herpes gestationis, subepidermal vesicle with eosinophil.